Good morning, everyone. Thank you for joining us today for the fourth in a series of revenue cycle improvement webinars with BKD. I'm Kate Stenyam with the National Rural Health Resource Center, and I'm joined today with my colleague, Sineva Hackman. Today's webinar will be recorded, and the playback will be made available on our website, along with the slides from the presentation. The webinar topic for today is hydration infusions, charge capture, and medical necessity. Our presenter today is Jennifer Goins. She is a managing consultant with BKD. Before turning it over to Jennifer, we have one poll question. Sineva, please pull up the poll. If everybody could take a minute and respond to the poll, when billing hydration services is the start-stop time of the infusion required to be documented? Give everyone a few more seconds to complete the poll. Thank you, everyone, for participating in the poll. If anyone has questions during the webinar, please type them into the chat box. Otherwise, there will be an opportunity to ask questions at the end. Jennifer, I'll turn it over to you to get started with the presentation.
Great, thank you so much. I was loving seeing those answers on that polling question. So good to see that I think it was 100% said yes. The answer is yes, and we will kind of cover that as we go through. So thanks everyone for joining. I think it's probably kind of early for you guys, so hopefully you've had your coffee and are kind of ready to go to talk about hydration infusions and kind of medical necessity around those and how to do some good charge capture. So if there are questions, definitely type those in, and then I'll kind of try to keep my eye on those to see if we have anything come in. So our agenda for the day is we're going to go through some background about kind of why hydration infusions are complicated, kind of what's necessary, and kind of why this is an important topic to kind of go over. And then we will go through some definitions about hydration and infusions and injections. We're going to talk about the hierarchy, which are the rules around facility billing. We're going to go over some rules and guidelines. I've got a couple of scenarios in here that we'll walk through that you can use as kind of practice, and then we'll wrap up with lots of locations and kind of resources to point you towards of where to go for help when you're working on hydration and infusions. So let's jump into the background here. So really, I guess the question is, why is coding and billing important for hydration? And it's kind of, it's multiple fold here, but it's really trying to make sure, one, that you get the appropriate reimbursement for the services that you're providing and kind of those resources that patient is taking up while they're at your facility. There are complicated coding rules around infusions just in general. So I have been working with CPT codes for a long time, and I would say this is probably one of the most complicated areas to really try to grasp the rules, the regulations, and there's just a lot of requirements around here. And that's why this makes it so challenging. When you have complicated rules, that's when a lot of mistakes can happen. And there's a lot of monitoring going on by several government entities right now. Your recovery auditor, so for your region, Cotivity, they right now have hydration and chemo as an audit topic that they're looking for. So for sure, those RACs, those recovery auditors, have this kind of in their vision, their sites. They're monitoring this. And again, I think it's just around those complicated rules. You also have Novitas, who is your MAC for the Delta region, and they currently have multiple injection and infusion drugs that are on the targeted probe and educate list. While our topic today is specific on hydration, typically when you start talking about other injections and infusions, it all kind of gets lumped together. And so I could see where they could, once they get that documentation, just take a peek at what's going on with the hydration there. And then we do know that the comprehensive air rate testing, or the CERT program, that they're using benchmarks and they're comparing hours of hydration to others. So they're looking and kind of comparing facility to facility to say, you know, where are those hours and how many hours are these facilities billing for hydration? And if someone's an outlier, you're probably going to get a letter, and you're probably going to get a review where they're going to come in and want to know kind of and see what is going on with your hydration. So we're going to jump into the first part of the hierarchy. So just if you're not overly familiar, there's kind of a two parts to this hierarchy. There's the route of administration, which we're going to talk about first, and then there is kind of the type of medication or drugs that you're receiving. And both of those hierarchies are necessary to be able to understand and to get right what is considered, how stuff get coded, how it gets billed, and how you kind of count all of your documentation to make sure you translate that into the appropriate codes. So we're going to touch on this a little bit. Again, like I said, I know our focus really today is hydration. I promise you we're going to talk a lot about hydration, but we've got to kind of lay the groundwork here so that everybody's kind of on the same page here. So for the route of administration, an IV infusion or an infusion always takes precedence over an IV push and then an injection. So when we go to say, well, what are those definitions? Like, what is an infusion? It's going to be considered any substance that gets administered through a line for more than 15 minutes. So this could be chemo, this could be hydration, this could be an antibiotic. It's as long as it's infusing into you or into the patient for over 15 minutes, it's considered an infusion. The 15 minutes is kind of important because if it's 15 minutes or less, then that's where they consider it a push. So this is like an injection into a line, like an IV line, and most of the time these are usually pretty quick. Sometimes, just depending on the drug, they do have to be pushed a little bit slower, but that's where that 15-minute mark kind of comes in. So anything less than 15 minutes is a push. Anything more than 15 minutes is considered an infusion. And then your injection, probably more what everyone is much more familiar with. This would be an injection that is it's an intramuscular or subcutaneous. So these are more like if you get your vaccines, flu vaccine or whatever, this is kind of where that falls in. And then let's talk about the definitions for facility billing here. So when we talk about those different types of infusions, so you have an infusion and you have pushes, there's some verbiage that goes along with those that really kind of clarifies the different types of what's considered an infusion and then a push. So initial. So on the facility side, this is really the type of therapy that you're getting. So, and you only get one per encounter. There are a few caveats that they give you. I will let you read those in like the CPT manuals where you could potentially have more than one per day, but I'm going to say the 80-20 rule, or it's actually probably more like 90-10, you're only getting one per encounter. And then sequential is considered either for an infusion or a push when you have a new substance or a new drug following that initial. So let's say you get an infusion of antibiotic A, and then followed right after that, you have to get antibiotic B. So that would be a sequential infusion here. Now, I do have an exception here. Thankfully, CPT finally created a new code a couple years ago and it's just specifically for a push of the same drug. So you now have pushes for an additional drug and then pushes for a sequential. So if a patient comes in, let's say, to your ED and they have kidney stones and they're in a lot of pain and they may get an injection of a pain medicine when they first get in, and then 2 hours later they get another push of that same pain medication, then that's when you would get that additional drug push. It wouldn't be considered sequential because it's not a new drug. And then concurrent, really for most of the time, concurrent is probably really going to happen more with your more complex drug infusions, maybe more with chemo, and it's where you're getting two substances infused at the same time. And regardless of however long these infusions run, you only get one concurrent a day. So kind of confusing. That one's a little more challenging, but I would say those typically happen in more complex situations. And then we have the definition for additional. And so this would be, and I've kind of thrown that around a little bit when I was talking about sequential. And so additional is you're getting an infusion of the same drug for more than 1 hour. So as I said before, the patient that may get antibiotic A, if they only get one antibiotic when they're in your facility and they get it infused over 3 hours, you would have an initial infusion for 1 hour and an additional infusion for 2 hours. So we will move on to now the second part of the hierarchy, where we are now looking at the type of therapy. So we have the route of administration, and now we're going to talk about the type of therapy. And chemotherapy is always at the top of that. So anyone who's receiving chemotherapy, that is always considered the highest drug type that you can get, and that's where all of your initials kind of would start, would be with the chemotherapy. The next would be if the medication or the drug is considered therapeutic, prophylactic, and diagnostic. So that would be where your next section goes. And then hydration is always at the bottom. So the reason we're kind of going through all of this is we can't just jump into hydration. You kind of have to understand what the rules are and kind of what these hierarchies are in order to be able to understand kind of where the hydration falls and when it can't be billed separately. So let's talk through then what these definitions mean. So I think it's easier to start with the therapeutic, prophylactic, or diagnostic. So this is really any kind of drug that's going to be infused that is not hydration. And we'll talk about here in a minute, like what those substances are that are considered hydration. And then chemotherapy, this is really going to be considered if the drug is chemotherapy or if it's a highly complex drug or biological agent. So if it fits into those categories, then it automatically falls into the chemo section. And chemo actually has its own section for drug infusion that is separate than the therapeutic, prophylactic, and diagnostic. So if you're not providing chemo at your facility, you can kind of breathe a sigh of relief. It takes out one level of complication here. And then the last item here is incidental hydration. And well, you're probably like, why are we talking about incidental instead of talking about real hydration? We will. That's the next slide. It's just really, really long. So incidental hydration here is when a drug is given to help administer a drug. So if it's the hydration or the saline fluids have to run with the drug at the same time, that's incidental hydration. It's not true hydration. Or if you, and we'll talk about this some more again, if you have to mix the drug with saline or with some other substance that's considered a hydration substance, that's not hydration. That's just how you're having to provide that medication. And so in those instances, that's considered incidental hydration, and it is not separately reportable. So then let's talk about actually what is hydration. So hydration is really considered the replacement of fluids via an IV infusion that has, and these fluids are prepackaged and usually contain electrolytes. So here are several of the options. So you might see D5W, distilled water, saline, any types of these. These substances are what they consider to be hydration. And this is specifically coming from that coding clinic there, which is helpful because it kind of also gives you the CPTs that you could be looking, or the HCPCS that you could be looking for to report on the claim when a patient is getting one of these bags of fluids. So let's talk through some of the rules and the guidelines that are specific for injections and hydration. So I've already alluded to there's lots of kind of rules and they're complicated, and that's very true. And I feel like kind of lots of entities have made sure that they've put out some rules, put out some guidance. So these really are the places that you need to go to look for these guidelines to help you in determining how you do your billing for these infusions and then mainly for the hydration. So you definitely want to look at the CPT manual. There's a whole section regarding that kind of leads up to infusions and injections. I read it almost every time I go to look at infusions and injections. It's just a refresher, and it's some good information is there. Medicare also has some guidelines and references, and then obviously your MAC. You definitely want to go out and look at what your MAC has published, what kind of rules, if there's LCDs, which are local coverage determinations, around either the drugs or the hydration, and that can really help clarify some of the documentation requirements, some of the billing information that you would need. So what I have done here is taken some of these rules and guidelines, kind of outlined what is needed, what is necessary, and then we'll look through, going through some of these guidelines, then we'll look at how it gets documented on an order and then how it gets documented as being administered and all of the important pieces kind of that you're needing here. So these are your basic kind of, and this really applies whether it is a drug or it is hydration. That these are kind of the rules that you want to live by, and you want to make sure your clinical staff is documenting as such. So you definitely need an order. You have to have an order for the drug or the hydration fluids that is signed and dated by the physician or the PA or the NP that has the drug name, the dose, and their route of administration. So how's that patient supposed to receive it? Is it a push? Is it an infusion? And then the administration of the drug needs to include the name and of the drug and if it's infused or injected. You need the dosage amount that the patient received. You need how they received it. And then you need start and stop time. So I've got this here. I've got it flagged. I've got more information throughout, but we're going to talk about start and stop time all the time. And I think as we saw that the pre-presentation question, yes, I'm glad to know most people understand, yes, start and stop time is required, and it is required for hydration. So here's an example here of an order that we've got the patient's name, kind of that patient identification information, what the date is, and then that this, what the drug is and what the patient needs to receive, and then what the rate is and how they need to receive it. So they need to get 100 milliliters an hour of this antibiotic. We can see that it was electronically signed by the doc, the date, and the timestamp. So we've got down here kind of all those components that we had just talked about, what is necessary to have on the order for this patient. And then we'd go and look at, here's an example of a MAR, or a medication administration record. And I will say this is, I made this one to be kind of like the perfect example of one. You may not see your MAR be this well documented. These are definitely the components that you really would like to have documented. And I would say if you don't have all of these components documented clearly in your MAR, have a conversation with your IT team that handles your EHR. And to see if there can be some tweaks to your system to make sure that you get the stop time documented. I know that seems to be the most problematic area when we look at documentation is most everything has, start times and the dates and what they're receiving and the rate at which they're receiving it, and they don't have the stop time. And that'll get you because you can't really justify the time for charging for these services. And just to make sure that everyone is, we're on the same page here, the drug infusion charging, so the infusions themselves are time-based. So your infusions, they're looking at hours, so you have like the initial hour and then additional hours. And that's why it's so important to have your start and stop time, is you have that documentation that will justify the length of time that the patient received those fluids or received that medication. We can't, as much as you want to try, I'd like to say, but I know they got a liter, so they got a 1,000 milliliter bag. They got it at 100 milliliters an hour. I know that took 10 hours to administer that. Why can't I bill 10 hours? Because I don't have a stop time. And it's like, well, how do we know they got the full bag? How do we know that they actually got the full amount and it didn't get stopped after 2 hours? So that's where the issue is with needing those stop times. So you can't take the rate and do the math and figure out how long and try to use that to justify billing for your infusions that are time-based. So you really need that start and stop time. And so here we're just checking off those components that your MAR includes, the drug name that's to be infused. It's up here at the top. That we've got the dosage, that it's where it's going in at the site. Up here it also indicates that it's an IV piggyback. That's what the PB is for. And so the drug is going in. This amount of drug is going as an IV piggyback with normal saline. So this would be a situation, as we talked about before, this would be incidental hydration. This would not be separately billable as the hydration. This would actually be a therapeutic infusion for this drug. And then we've also, as I mentioned, we have those start and stop times. So we've got the date with the start time here, and then over on this side, we've got the date and the stop time here. And then let's look at another example. So this is an order for an IV push. Very similar. We've got the drug, we've got the amount, we've got the route, we've got it signed and dated by the physician. And then here's the other MAR here. Again, we've got the drug, we've got, again, injection, we've got a push. Now here's one where, because this is fully clear that these are pushes, this is one where we don't have stop time documented. And I think this one's a little bit more okay. It's probably still a good practice if you can get the stop time. A lot of these drugs, though, when they are pushed, they're pushed pretty quickly. So it's kind of the start and the stop time are usually about the same. There are some drugs that do require to be pushed over slower, like that full 15 minutes. So those might be good ones, too, to get the stop time documented. But here I made sure that we just had like stop times and that these are for the pushes as well. So we've kind of talked through the rules and the guidelines that are necessary for good infusion documentation. Now here's kind of the flip side of the things where you can't or you shouldn't be billing for infusions or injections or hydration in these different scenarios. So if a patient is having some type of procedure, It could be an MRI. It could be a CT scan. They're having a minor procedure. They're in the OR. If those infusions are inherent to that procedure, so a patient's getting an MRI or CT scan with contrast, that push of that contrast is not separately billable. That is inherent to that procedure. That's the only way they're going to get, well, I shouldn't say only way. It's one of the ways they're going to get that contrast into their body. And it has to be done in order to do that radiology scan with that contrast. So that push is not separately billable. If the patient is in the OR, a lot of times they've got fluids running, they may have an antibiotic running while they're having a procedure done. Those infusion and that hydration, that is not separately billable. That is all part of what is necessary to perform that OR procedure. So you want to make sure that those are not being separately billed, separately charged. Same thing, if a patient's having a scope like a colonoscopy or an EGD, and they get an IV line set up to help maybe run in the sedation, and they keep it, they keep the saline running until the patient's awake, they're good to go home. That is not hydration. So if it's really done in connection and part of those procedures, it's not separately billable. So there's some other things here, like, again, we're going to reiterate that you do not bill hydration if it's an IV piggyback, because the saline is necessary to accommodate that therapeutic drug. So I know there's some drugs that are, pretty nasty, that are, if, caustic to your veins. You can't just go straight in with the antibiotic. It has to be mixed with that, those fluids or that saline. That is not hydration. Again, if you have to mix the drug with a bag of saline in order to administer it, that is not hydration. And then really, if the rate or that patient really just has that line in as a what they call a KVO rate, or a keep the vein open rate, that's not considered hydration as well. That's just really, it's like a maintenance line to keep there in case they need to push any other medications, the patient has any complications, or would need a bolus or a massive infusion of fluids because they've had some sort of complication. So those are kind of those three areas where saline or any of those kind of prepackaged fluids that we've talked about, they're not considered hydration. So you do not want to be billing for those. So let's talk about some of the medical necessity around infusions, injections, and hydration. So, and specifically I want to focus on here on hydration. So very important to look out at your MAC site for LCD information that they may have published either regarding the drug or regarding hydration. As I mentioned before, Novitas does have an LCD out regarding hydration. We will look over that here very shortly. I've got several sections of that LCD pulled out so we can kind of review some of that. So if you're not in a MAC region for Novitas, make sure you go out and check your MAC to see if they have something specific to hydration. Pull that LCD down, read it, reference it, use it as education. I can't say it enough that that's really where some, good criteria, good rules are that you need to make sure that you are following. And then really, you really need good clinical documentation to support that medical necessity. So it's a little bit, I think, easier for drugs to be clear, when there's a medical necessity reason for why the patient's getting that drug. It gets a little more complicated for hydration because I feel like at least a lot of the charts that I have reviewed over the years, that seems to be a little more lacking where they're not as clear that the patient is dehydrated. It may be obvious because the patient may be coming into your ED because they have a severe case of gastroenteritis, and it is obvious that the patient is dehydrated. They've been, vomiting for 12 hours or whatever. But unless they write it, it's, you can't make those assumptions. So there may be times where a query is necessary to that physician, or maybe there's some education that needs to go out to the physician group specifically around hydration to say, hey, we need a little more documentation and information that is a bit more clear about why you're ordering these prepackaged fluids for. Is the patient dehydrated? Do they have hypovolemia? Is it because they have, uncontrolled diabetes and they're very hyperglycemic, and you're providing them for that purpose? So just making sure that that clinical documentation is there. As I said, query, but it might be easier to do kind of some education first, so you don't inundate the physicians and the clinicians with a bunch of queries there. And then obviously having your appropriate ICD-10 application, it's important for the coders to code it appropriately, but again, they can only code as good as the documentation is. So those kind of things go hand in hand, especially when you have an LCD that is out there and it's very specific to the codes that are covered and considered medically necessary for payment for those services. And then this last bullet point here, and I've got this italicized because this is also, I think, probably one of the hardest areas to grasp and to be able to understand and to make clear. And this, again, I think is where a lot of good conversation needs to happen with your clinical staff. You may need to educate them on what we need clarified in the documentation, and then they can educate the coding staff or your CDI team, whoever that you may have at your facility, so it's clear as to when do hydration fluids stop being hydration. You can't necessarily rely on this based on a rate that the patient's getting. That patient who has that gastroenteritis who comes in may get a huge, bolus, get a liter of fluid within an hour. And then the second bag gets hung and it gets changed to 75 milliliters an hour. So it's a much, much, much slower rate. Are they no longer dehydrated at that point? Those are some of the questions that you would want to go back to clarify, because you need to know that to know how many hours you can count for that hydration. And the reason I say you can't rely on those rates are patients have other comorbid conditions. They could have kidney disease. They could have heart failure. And that kind of patient population, you just can't dump a liter of fluids into them in an hour or less. You could send them into kidney failure. You could fluid overload them. They could have worsen their congestive heart failure. So for patients that have other conditions, the rate at which they have to receive their hydration is different than a patient who doesn't have those comorbid conditions. So there's another more complex issue that comes into play here. So I think this is a really good area to really make sure you understand with your physician group how and when, the hydration is kind of considered done, so that it's clear that when someone's, doing the charge entry for those services for that hydration, that they know what they can count and kind of what they can't, because now we're just leaving the IV line in case we need to push anything else or administer any other drugs or fluids. So here is where I said we'd get into looking at the Novitas LCD. So I have a few things, number 1, 3, and 9 that I've kind of circled here in red. I have the link to the LCD down below. I don't know when you go to get it. You might, I think I tried to do it as a hyperlink, so if you have the slides, you may have to do the control click, and it should be able to take you out here. Otherwise, just copy and paste this into your browser, and you can go and look at this. So here, the one thing that I want to talk about that I've highlighted here, these are some of the limitations that are specific to Novitas if they are your MAC. So they have, number 1, is they don't consider it to be medically necessary if the person or the patient receives less than 500 milliliters of fluids. So that's where, devil's in the details. You've got to see what was ordered, how much was the patient administered, how much did they receive, because the patient could come in, get a bolus of 500 milliliters or 450, and then be much better and leave. And that may all look like hydration to you, but according to Novitas, they're saying, no, that is not considered medically necessary to be hydration, so you wouldn't bill that as hydration services. And then obviously number 3, which we've kind of talked about before, is hanging those or giving those fluids at the same time of chemo. That's not hydration, or just prior to giving the chemo. That is not considered hydration. And then number 9, this was another one, again, is giving those drugs either as the mix or running at the same time. That's considered incidental hydration. So those kind of guidelines that I've given, those are outlined in the CPT manual, and then the MAC is reiterating those things here as well. And then a couple other things that, again, devil's in the details that are kind of embedded here within this LCD. Under their utilization guidelines, I've highlighted this whole sentence. And I would highly recommend take this back and noodle on this and have a conversation with your maybe chief nursing officer, talk to your physicians about this, talk to your compliance, because really what they're saying is they're going to pay for IV infusion once per day, and that they don't expect to see infusion therapy billed more frequently than once per day. So I would say, let's go back and look at this and kind of see and noodle over this. And this is under the LCD that is specific for hydration. So I think you may want to go see what's your billing trend, what are you guys billing for hydration, how many units, your patients that may be in OBS for a couple of days, or who may be, in the ED for a prolonged period. What's kind of going on with them? What's kind of your trend and how you're billing your hydration? And I would just, reference back. They're not giving you a whole lot of very specific details here. Like, they're not saying don't bill more than 24 hours. They're not saying that. But I think they're kind of leaving this open, and this is like lots of gray here on what are they actually meaning this. So that's why I'm saying go back, make sure you guys have, an understanding in what your interpretation is of this. So they're definitely indicating that they are monitoring this for utilization. And the other piece that I want to call out here, so I've got 2 links here. The first one, again, is back to that LCD. The second one is there's a local coverage article, or an LCA. It kind of cracks me up now that they've had to split these into 2 different components. So you have kind of the policy in the LCD, and then the local coverage article then references the specific CPTs, HCPCS, and ICD-10 that apply to that local coverage determination. So you'll need both of them to review. If you're just specific about the policy, just look at the LCD. But the LCA is really where you will see what CPTs and HCPCS this applies to. Back on that slide when we talked about what they consider to be hydration, those prepackaged fluids, it'll list out what those HCPCS codes are that you may want to make sure you have linked to those charges so that those show up on the claim as well when you're billing for hydration. And then this will be where it'll list out those diagnosis codes that in order to meet the medical necessity for hydration, that would need to be on the claim. And then this is here where I've got the number 3 and 4 highlighted. These are the documentation requirements that are in the LCD, where they talk about what needs to be clearly documented, the medical necessity for the hydration, and the volume of the hydration, of what the patient received. All of that needs to be documented. So again, this might be have someone at your facility take a quick look back at your MAR, that medication administration record. Make sure that you have that documented. Make sure nursing knows that they need to document how much that patient received. And if it's not there, then find out if there's an easy way it can be added to your documentation. And then number 4, here it is again, we're going to talk about Novitas has set down the rule that hydration must have start and stop times. So if you go back and start looking through your documentation and you are missing that start and stop time, you do not want to bill for hydration because you don't have the documented components necessary to support those services. So let's walk through our first scenario here. So you might, if you've got a little pencil and pen or paper in front of you, you might jot down, I'm not expecting people to know all the CPTs, but it might be good practice to say, like, what would I do? I would do an initial infusion, 2 pushes, additional, would I code the hydration? So this might be a little test. And if anybody has the slides, don't look ahead to the answers. So our first scenario here would be a 40-year-old female presents to the ED with nausea and vomiting for the past 15 hours. The patient is given an IV infusion of D5W for 4 hours and 2 IV pushes of phenergan. The patient is diagnosed with gastroenteritis and dehydration. So how is this coded and or how would this be billed? So when we start looking through the answers here, the top I've got the same scenario restated, and what is underlined in the red are kind of the important components that jump out here that you need in order to be looking at how you would do this here. So we know we have the IV infusion of the D5W, which is one of those prepackaged fluids that's considered hydration. The patient received it for 4 hours. And then the patient also got 2 IV pushes of phenergan, which is an anti-nausea medication. And they were diagnosed with dehydration. So because of the services that the patient received, we know from the first hierarchy, infusion should be before a push. However, the infusion was for hydration, which is at the bottom of the hierarchy. So their therapeutic, prophylactic, or diagnostic medication they received is the phenergan. So that becomes your initial. So you have an initial push. You have an additional push of the same substance because the patient received 2 phenergan pushes. And then you would do 4 hours or 4 additional hours of hydration. So your initial is that push, again, because it's the therapeutic prophylactic drug, and then your hydration becomes last. And let's look at scenario 2. This one's a little more tricky, and this one's, the answers are across a couple different slides just because we have a lot to talk about here. So this is a 52-year-old male presents to the ED with bilateral flank pain, nausea, and vomiting. The patient has an IV started with Ringer's lactate, an IV push of phenergan, and hydromorphone. The patient has a CT scan with an IV push of contrast and is diagnosed with bilateral pyelonephritis, which is a kidney infection. The patient is given IV Rocephin, is infused for 45 minutes at 10 a.m. and then again at 10 p.m. So how would this be coded? So, so we're going to start here with the infusion and the therapeutic prophylactic, which is the Rocephin. It's an antibiotic. So the patient was infused for 45 minutes at 10 a.m. and again at 10 p.m. So they would get 1 initial infusion because the Rocephin ran at 10 a.m. for 45 minutes. So we're almost to that hour. We're past the halfway point in the time frame which the CPT book allows you to bill for that service. So they got 1 initial infusion and then 1 additional IV infusion because it's the same drug. So they've got the 45 minutes at 10 a.m. with the 96365 and the 45 minutes at 10 p.m. represented with code 96366. Now let's talk about the IV pushes. So the patient got an IV push of phenergan, hydromorphone, and contrast when they had their CT scan done. So here they would get 2 IV pushes of each sequential drug. So the initial would be that infusion that the patient received, and now the pushes are different types of drugs than the Rocephin. So because we do ephedrine and hydromorphone, two separate drugs, so they're considered sequential pushes. And then I'm hoping everyone got right that we would not charge anything for the IV contrast that was pushed. So this doesn't apply. Again, it's part of that CT scan procedure. And then we end up at the end where the patient had the IV started with Ringer's lactate. Now we know that that solution is one of those prepackaged fluids that is considered what a patient would receive for hydration. However, that documentation, the patient had no mention of dehydration or volume loss. So there's not a diagnosis that would support this medical necessity for these hydration services. So this would be one where I would not have coded or billed for the hydration there because it's not clear why the patient received them and it's not medically necessary or doesn't meet medical necessity by, especially with that Novitas LCD. So let's talk here for a couple minutes about where you can go for help, where you can find information, guidelines, all sorts of good stuff here. So the Medicare Claims Processing Manual, Chapter 4, Section 230, has lots of information regarding injections, infusions, hydration, all of that information. If you don't know how to access this, you can literally just copy this bullet point and paste it in your browser like Google, and it'll take you right to the link to find this section, or it'll at least take you to this chapter, and then you can find Section 230. As I mentioned before, the CPT manual, very helpful, lots of information. There's, I'm going to say it's probably at least a page and a half, maybe more, of information that is before this section. I did type out the full section of the CPT manual. I'm not going to read it because it is exceedingly long, but I would recommend going out and reading this. There's lots of information here. There's all sorts of guidance and help and information that clarifies, you know, what you should and kind of shouldn't be doing, or what you should be looking at, and they give you some scenarios too to kind of help understand these complex rules. Also, lean on your CPT assistant and your coding clinics for clarification. Those usually, especially the CPT assistant, usually has some sort of scenario that they'll try to walk through and help it be more clear in answering a specific question. And then again, as I've said, go out to your MAC. I think for the majority of everyone there, it is Novitas, and look at what kind of criteria they have out. What are their requirements or their medical policies around hydration specifically? Again, pull down that LCD, pull down that LCA, read that over. Just remember those things can be updated. So always, if you're going back to reference it again, always go pull the most recent version online so that you're referencing the most up-to-date information. And again, this is where I want to swing back around again one more time on the start and stop times. So this is, again, another area where things get a little tricky. So in the CPT manual, and kind of the best practice by the AMA is that you should document start and stop times, but it's not required. I don't think, I mean, it's like great. That's a recommendation that you should, but it's not a required statement by them. You need to look to your MAC. Again, Novitas is very explicit. You have to have start and stop times documented. So I don't think that should be in any question, you know, to your providers or to anybody, your nursing staff, when you're talking about this. Absolutely 100% start and stop times documented. If you're in an area where Novitas is not your MAC and the MAC is silent on the issue, and doesn't indicate whether you need to have start and stop times documented, then you need to go back to the CPT manual. And it says, in the manual, it says to use the actual time over which the infusion is administered to the beneficiary for time-specific drug administration codes. If basically taking that statement, they're saying you need to document. The only way you're going to know is for the actual time is you'd have to know when it started and when it stopped. So in a nutshell, I would say always get your start and stop times documented. It'll be one less thing to have to worry about should anybody question the services that you've billed for injection, infusion, or hydration services. So I've talked a lot. We have, I think, about 10 minutes left. I'm sure there are some questions. I don't know, is there any questions that have come in? I'm trying to see on the little question chat if there's anything there, or does anybody have anything that they would like to ask at this point? I think is that you hit *2 on your phone to unmute your phone to be able to, if someone is brave enough to ask a live question.
Yep, you're correct, Jennifer. It's *2 to unmute your line, or you can type your question into that chat box.
I will say, don't be afraid of billing and coding for your infusions and your hydrations. I don't want that to be kind of anyone's takeaway from this. The takeaway really is just needing to make sure that you have the documentation elements there to really support the billing and the coding that you do, so that if your MAC or you get a cert letter or the recovery auditor comes in, that you have that documentation to support why you billed the way that you did. So please don't take this as like something scary. It's just a little bit of a challenge, and just making sure that you have those documentation elements there, and then you have someone who can take that and then translate that into appropriate billing. Do we need to do the last, like the post question at this time? I'm not seeing anything come into the chat box.
Yep, Cinema will pull up the poll question right now. And as people are filling that out, I just wanted to say thank you, Jennifer, for the great presentation, and to remind everyone that this webinar was recorded and will be posted on our website. And the links to our website, the events, is in that chat box. I'd also like to remind everyone about our final webinar in this series, which will be held next Thursday at 9 a.m. Central. And the topic for that one is revenue integrity, denials management, and charge capture best practices. And again, that will be led by BKD.